think it's okay to get started.
Sure.
Okay. All right. Well, thank you very much for coming today. I really appreciate it. It's a small audience, and I know on some level here, like I said, I'm going to be speaking to the choir because all of you are familiar with the work already, except, and even Dr. Di Tommaso to a limited degree here. So I'm going to go ahead and zip through this. Is there something you want to
Yeah, Kurt, so what we're going to do now that we're ready to start is we're going to ask you to present, and we understand you've got a good succinct presentation, 20, 30 minutes. Usually what happens is we'll either wait till the end, but traditionally with most of the group here, we'll probably interject some questions for you. After you make your presentation, we're going to ask you and everybody else to leave as we discuss your presentation, and then we'll call you back in for the committee's decision.
Very good.
Anybody have anything to add? Okay. Sound like
Okay.
a good agenda?
Sounds like a great agenda.
Okay,
We'll
go.
Okay. All right. Obviously, what we're dealing with today is veteran suicide. The main problem is that it has been an epidemic. I mean, all you need to do is read the news, and you'll find that veterans do indeed represent a special population of interest when it comes to suicide risk. Some of the data is very controversial because of the fact that to see how much, in some cases, the veterans are seen to be 2.5 times at risk than the general population. There's some research that suggests that, but it's really hard to know how many veterans actually do by virtue of the fact that data can be very difficult to find. A majority of the veterans don't use VA facilities, use VA medical treatment. But some figures go as high as 22 veterans per day die from suicide. So the main problem is prediction of suicide remains elusive to this day. It's just not possible to determine who's going to go on to die by suicide.
Kurt, what's the range on that 22 a day? Where are they getting it from, and what's the range of it?
The VA's been putting a lot more efforts into researching that, working. Unfortunately, it's not consistent with all 50 states, so they're basing it on some actuarial data and its projections. They projected to 22 per day. I can't tell you the algorithm goes into that. Again, we don't know. We don't always know. No individual or set of clinical risk factors assessed at a single point in time can reliably predict future suicide risk. Most of the decision making, particularly in this study, is based on clinical judgment, naturalistic clinical decision making, and of course, people sometimes find that faulty because of bounded rationality and cognitive limitations. Also, there are some limitations with regard to using standardized risk assessments because attempts to make them increase their specificity has led to decreased sensitivity and vice versa. So it's really important that mental health professionals be able to distinguish and discern what individuals are really at the highest levels of risk to engage in self-directed violence. Now, you'll notice I use the term self-directed violence. That's instead of suicide, that's a nomenclature that's used at the VA. It takes into account anything that a person could possibly engage in. It's violence towards themselves. So it's really important in this case that providers be very familiar with evidence-based suicide risk factors, and that, of course, is key to identifying those who are at the highest level of risk. The problem with that is there's well over 75 different risk factors, and I think it's very hard to synthesize all of those at one particular time. So it becomes more important to look at specific risk factors, particularly from a behavioral point of view. So the first thing we might want to take a look at is past attempts. This keys right into my one of my hypotheses, at least. You can see here half of those who died by suicide have attempted suicide, or previously, and 1 out of 100 suicide attempt survivors die by suicide within the next year. So 100-fold greater than in the general population of risk. All right. Having a psychiatric disorder by itself, it does increase risk, but most people, unfortunately, who have psychiatric or substance use disorders don't engage in self-directed violence. So the literature suggests that comorbid disorders, particularly those that are listed here, oftentimes come together to increase the risk. And combination of significance is their combination depression and anxiety disorders greatly increase the risk, and you can see the odds ratio is 17. Comorbid personality disorder also, we know, increases that risk because of problems with emotional regulation, problem solving. Alcohol, 20 to 25% intoxicated time of death. The figure is actually much greater overall when they do autopsies. They find alcohol in the blood streams of people maybe 75 and greater % of the time when they do the autopsy at the time of suicide. So alcohol is a major contributor. Demographic factors. Young adults attempt suicide more often than older adults. The risk for death by suicide increases with age. Again, no surprise, men are 3 times more likely to die by suicide, although women attempt suicide more than men, and that's also true percentage-wise within the VA system, although the literature suggests now that the gap is quickly closing on that men are increasingly attempting suicide at the same frequency as women. Let's see. The difference is obviously lethality, particularly firearms, which is, of course, the #1 method that men employ. Hanging and poisoning account for second and third as far as the methods. White people account for about 90% of suicide deaths in the U.S., and again, no surprise, 72% by white men. The median age in the VA population is in the mid-50s, 52 to 54, according to the latest data. That seems to be the mean age of death by suicide, which would factor in the post-Vietnam population. Hopelessness, I'm preaching to the choir on this one. Hopelessness, we know, mediates the relationship between depression and suicidal ideation. Impulsivity, again, increases the likelihood that an individual is going to act on suicidal thoughts, especially if they have problems with disinhibitory controls. Certainly, people have traumatic brain injury, have problems with executive functioning that affects that. Certainly, substance abuse, disinhibition, and as I said earlier, alcohol is a major driving force. Medical illnesses, chronic pain, chronic disease, and recent surgery increases suicide risk. Now, these all play into the risk factors that predictors that we'll be looking at as we get into my hypotheses. Family factors. This is, we talk about distal factors, historical factors, and one thing that oftentimes happens in ERs is that these factors are totally overlooked. And unfortunately, these are the things that contribute to the distal risk, long-term risk going forward. And again, having a first-degree relative who commits suicides increases the risk by 6-fold. Heritability suicide is in the 30 to 50% range. We know there are genetic factors that contribute to this. We know that serotonergic metabolite factors found in spinal cords are one of the biological markers that is looked at. Cortisol levels in the HPA axis. Maybe one of these days we'll have a real good test for biological marker that can do this. That would answer all of our problems, maybe on some level. We all know that never being married, single status, being widowed, divorced, married without children conveys a greater risk for these folks. Risk also increases in patients who live alone or have experienced a failed relationship in the past year. Now, if you notice on active duty, a lot of those suicides that you hear about are in close proximity to the breakup of a significant relationship. Adverse childhood experiences increase the risk in suicide in adults, and it's at least partially mediated by the presence of alcohol, depression, illicit drug use. So physical sexual abuse, studies have shown that, again, the HPA axis involved cortisol levels, increased unregulated cortisol levels do increase future risk of suicide. Access to means, particularly critical in the veteran population. We've already talked about that. Aggression and violence. I'm going to talk a little bit about that hopefully in my discussion today, because we'll see that violence towards others came out insignificant in this study in terms of risk factor. At least providers don't see it as an imminent risk. And it came out insignificant, so we'll talk a little bit more about that. So in order to figure out...
back on that previous one, it seems like there is some influence of violence as children.
Yeah, violence, men with expressed violence as children, 3 times at risk to engage in self. Yeah, there's a lot of studies that suggest violence is correlated with suicide. Unfortunately, what I'm suggesting is providers don't.
Right.
In this case, in this cohort, in this study, didn't really give it as much import.
Correct.
When they were making their risk assessments.
Okay.
It didn't really, so it wasn't really positively associated with high risk.
By the providers.
Correct. And that's what this is about. This is about looking at provider decision making. Yeah. Okay. So we need to use suicide risk stratification to determine level of risk. So we, obviously for resources, clinical effectiveness, and obviously it informs treatment and disposition by doing that. The problem is, up until this point, nobody's ever really looked at it to see if it works or if there's any clinical utility or if any of these risk factors have any meaning. That's when Greg came up to me while I was working at the VA and says, does moderate risk have any meaning or not? And you poll people and everybody comes up with something different too. There's no consistency in what people believe moderate risk really is. So, so that's the basis of the study, is to look at risk stratification to see if it really works and get a sense of what providers are looking at that informs those decisions. These are the VA practice guidelines. This is sort of, I guess, a prescriptive method that they use to guide one's stratification attempts. So I just put that into the slide for your references. I'm not going to get into that too much at this point. Naturalistic clinical judgment, the theoretical basis for this study is that, in fact, and the literature suggests most clinicians really like using clinical interview when they do risk assessment, and in favor of actuarial tools. It's not always possible to use actuarial tools. So again, I'm not going to get into this because I'm my audience here, but obviously we're limited cognitively. There's bounded rationality. We tend to use availability, representative heuristics. We tend to use bias, non-base rate biases, base rate biases, and so forth. So all of these things affect one's ability, not to mention the emotional stuff that's involved. Clinicians have their own view. Okay. Again, normative theory is more positivistic. Those who criticize naturalistic critical judgment, and there are indeed studies that suggest that actuarial tools sometimes do a better job than naturalistic clinical judgment. So, and some cases, the problem is you can't always quantify risk in complete and known ways. So again, it does have its limitations here. And not to mention suicide is such a dynamic factor, just you can't predict what the proximal events are going to be. Prescriptive theories, clinical guidelines, clinical policies designed to help reduce variations, and it's used to encourage practicing more to the evidence-based. And in this particular study, we do use a checklist that's used in the ER. We'll get into that later. That is used to maybe help give some guidance to clinicians in the ER to what to look for as far as evidence-based risk factors. This I like. I often say I think psychology should be specialized like the medical field. You know, if somebody's doing risk assessments and suicide in the ER for 20 years, they're probably going to have a pretty amazing expertise. And again, experts are assumed to apply metacognition to their processes, possess superior long-term and short-term memory. Again, intuition does receive some play in this. You know, sometimes people just, they get it. They just get this clinical hunch. They know there's something here. A lot of times they're right on the money, and that just goes along with being able to be an expert in a particular domain for so many years. So let me move on. All right, so I'm going to get into my 5 hypotheses. And the first hypothesis is it was hypothesized that veterans' reports of a past suicide attempt within 30 days of evaluation in the ED would be positively associated with a provider rating of high risk. Hypothesis 2, it was hypothesized that the following modifiable risk factors: current suicidal ideation, current psychiatric or substance use disorder, hopelessness, command hallucinations to hurt self, highly impulsive behaviors, agitation or severe agitation, perceived burden on family, chronic pain, serious medical problems, homicidal ideation, aggressive behaviors towards others, available method for suicide, and inability or unwillingness to engage in safety planning would be more likely to be positively associated with a provider rating of high compared to moderate or low. Hypothesis 3, the same. In this case, we hypothesized that it would be positively associated with a provider rating of moderate compared to low suicide risk. Fourth hypothesis takes into account subsequent engagement in self-directed violence behavior over a period of 3 years subsequent to their evaluation and assessment in the emergency department. And it was a hypothesis that provider ratings of high risk would be more likely to be associated with subsequent suicide attempts than ratings of moderate or low. And last of all, it was hypothesized that provider ratings of moderate risk would be more likely associated with subsequent suicide attempts than ratings of low risk. So, methodology. Again, this is an archival study. Any veteran who had a formal suicide risk assessment conducted in the emergency department in years of 2012, 2011, 2012, were eligible for this study. There were some exclusions in this case because not everybody that comes into the VA is a veteran, number one. Incomplete data sets would have excluded them as well. Out of that, we were able to identify over 2,600 risk assessments that met inclusion criteria, and that was comprised of 1,560 veterans total out of those 2,600. It is a retrospective cohort design, again, using Veterans Affairs data out of 2 sources. One is the electronic medical records, which is known as CPRS at the VA. And the other one is the Suicide Prevention Applications Network, which has been operating since, I believe, 2009, 2010. It's all the VAs in the country have a system where they report suicidal events, and it's very, very comprehensive. It gets into methods, it gets into, where was the last department they had been seen in primary care by their neurologist. I mean, it gets into really a lot of detail. So all the data came from those 2 sources.
So would that include data from outside the VA too, concerning veterans, or just within the VA?
Just within the VA.
And that figure is different than the 22 per day of completed suicides?
Right. Right. This is just...
And, do you know what that number is, Greg, off the top of your head, Greg?
As far as for just the Philadelphia VA or the country?
The country.
Not offhand. I don't right offhand.
It'd be interesting to...
Maybe Greg has a sense of it.
I just don't know what off the top of my head.
Yeah.
Be interesting to include in there. I think people...
Yeah, I think it's in the actual draft. It's going down. The attempts, I know, have gone down in the last couple of years, just based on the span data. It's actually been, some of the programs have been really effective. The checklist that I referred to earlier is adapted from the Columbia Suicide Severity Rating Scale, and Dr. Brown was part of that effort. Rates an individual's degree of suicide ideation on a scale ranging from wish to be dead to active suicidal ideation with specific plan and intent. Identifies behaviors which may be indicative of an individual's intent to commit suicide. So we're looking at really behaviors here.
Craig, how do you like that compared to Beck's scale for suicide ideation?
It's apples and oranges, so it's the ideation scale looks at severity of ideation, more or less across a continuum, looking at various characteristics, whereas the Columbia is really a classification system. So it looks at discrete types of ideation or types of behaviors. So it's sort of a different, it's a different scale altogether.
Clinically, do you have any?
The SSI is not often used in clinical settings because of its length, whereas the Columbia is now being used quite a bit in practice.
Okay.
It's easy to give.
It's easy to give.
Relatively easy.
Yeah. Suggested too that any individual committing any behavior, exhibiting any behavior now is at 8 to 10 times at risk. At least that's what the study suggests.
Right.
Yeah. More likely to commit suicide than 8 to 10 times more. So when they come into the ED, the psychiatrists do have a checklist that's electronic, and that's where the predictor variables, these are all my predictor variables here. Not only do they look at these risk factors, they also recommend protective factors, identify protective factors as well, and I didn't get into that in the study. We're just looking primarily at the risk factors. And I'll just keep moving on there. Again, these are all the risk factors that are my predictor variables in this project. Procedure, again, submit an IRB to both Philadelphia VA Medical Center as well as the IRB here at this institution. It was, the VA determined that it was in fact a QI project, so therefore I got an exemption on this one. We also entered into a data user agreement for the SPAN data, which is the data that we use to identify the self-directed violence subsequent to the attempts. And again, that's at the Center for Excellence at Canandaigua, New York. Again, there's 2,506 eligible suicide risk assessments commencing January 1, 2010, ending December 31, 2012. So all the data, eligible data was pulled out of that. The SPAN data tracked subsequent acts of self-directed violence for this cohort through the end of 2013, December 31st, 2013. Given that we had obviously multiple attempts and multiple people coming in multiple times into the ER, we used randomization procedures. I did obtain the help of a statistician to help me clean the data up and come up with a randomized design to work through that. So, all right, demographic characteristics, and I'm not sure why that's hidden down there. Apologize. But anyway, this gives you demographic characteristics of this cohort. You can see African Americans are overrepresented in this study, which is kind of interesting. You'll see that too often, but it's an urban facility. Sorry that somehow this got cut off. It didn't get cut off on my machine, but the combat rated is really interesting because the majority of these people are not combat rated. I think it was only maybe about 20-some%, if I'm not mistaken.
If you hit escape, you might be able to manipulate.
Yeah, let me see what I can do with that. There we go.
There you go.
Oh yeah, even less. I'm sorry, 15.5%. So really, most of these folks are not combat rated, and it makes sense. I mean, the age is, like you said, the mean is in the 50s, and of course it's post-Vietnam era. So let me get back to this current slide. Okay. The evaluators, there were 104 different professionals that did these risk assessments, and over a 24-month period. 71 of those were physicians, many of them on staff. Some of them were indeed psychiatric residents from other programs, particularly Penn. and the remaining were either psychologists, LCSWs, or nurse practitioners. Average monthly visit to the ER was 100. The most frequent occurrence was in May of 2012 in this cohort. Out of those 2,506 suicide risk assessments, 844, which comprises 33.7%, led to acute inpatient psychiatric hospitalization. I was really surprised by that. I just, again, using my own heuristics, I would have thought it was going to be much higher than that. I was really surprised. While the remaining 1,622 were referred to outpatient specialty behavioral health services. Okay, so this comes from the SPAN data. 110 veterans from this cohort went on to engage in self-directed violence through December 31st of 2013. The monthly average was 10 events. The most frequent occurrence of self-directed violence was in February 2012, and that was 15. And out of that, 3 veterans ended up dying by suicide. By the way, all 3 were African Americans, 2 male, 1 female. Okay, so now we get into the results of my hypotheses. Using chi-square analyses, with a sample of 1560, we found that there was in fact a very significant strong association between an act of self-directed violence within the last 30 days and a provider's rating of high risk. And here's the data itself. It came out pretty strong. No surprise there, Greg?
You want to talk about that slide a little further?
Well, again, this represents the entitled, everyone that had, all the veterans that had gone in to have an emergency department consult completed and risk assessment completed. And again, out of that number, which you can see here, 75% of those people actually ended up getting a rating of high risk. Providers felt that was really important. If somebody had reported and engaged in an act within the last 30 days, that I think made the decision easy for them. Whereas compared to low and moderate risk. So what we ended up doing is we actually combined low and moderate to form a non-high risk category versus a high risk category. Okay? So that seems to be a good thing. And that supports the literature, right? Past attempt, best predictor.
I'm wondering about the other 25%.
Yeah. Well, what's your thought?
I got a guy who, or a woman who's attempted in the last 30 days and they're not considered high. 25% of the sample.
Well, maybe those people will be, because one of the questions they're asked are, do you have any history of past attempts, period. So depending on the story that you're getting, that's going to probably inform your decision making too, if it isn't within the last 30 days. That is one of the predictor variables, and we'll see the data for that as we go further. It's actually a pretty strong predictor. For the second hypothesis, we combined low and moderate categories to inform a non-risk category. And we found that there is a statistically significant positive association between 8 of the 12 modifiable risk factors and all 3 unmodifiable risk factors with evaluators' final ratings of high suicide risk when compared to final ratings of non-high risk. And here's the data for that. Again, I highlighted in red those risk factors that ended up significant. Many of them at the 0.001 range. And again, I'm having this little issue here with the, oh no, it's okay. Okay. And, it's interesting to look at the positive and negative predictive values. Again, I think we do a good job at figuring out who will not go on to attempt. or engage in self-directed violence, but we have a hard time figuring out who will. And I think it's going to be a problem for a while. All of these factors, I mean, the best you could get, the most, looks like, isn't it interesting, perceived burdensomeness, auditory hallucinations, command auditory hallucinations have a little bit higher positive predictive value. As you noticed before, severe agitation, homicidal ideation, aggressive behaviors, none of those came out significant. So providers didn't see those as significant for high risk versus non-high risk. That's a little concerning to me. I mean, I have to say, I think that could be a trait, there could be trait concerns, trait personality concerns there that put people at distal risk, chronic risk for suicide long term. And I just find it interesting that they don't consider that as significant for high risk, but that's the way it came out.
Can I stop you for a minute? I'm struggling with one thing, and it's not really a big deal, but I'm looking for, was there any place where you described, but actually behaviorally defined what a suicide attempt, what the kinds of suicide attempts are?
It can be any kind of, I didn't describe it in the dissertation, I don't believe, but I know from the VA's point of view.
I mean, from my understanding, you know, I know that you can't have an exhaustive list of every kind of behavior, but I'm kind of going back to Brad's point about the 25%. You know, if a person said that they took a piece of glass and tried scratching their wrist, and that they were in a very distraught state of mind, very depressed, and they had the intent, and that was their attempt, albeit, you know, for lack of a better way to put it, a feeble attempt.
Right.
But nonetheless, it counts as an attempt. That would be very, very different than a person trying to asphyxiate themselves, or you know, or blow their brains out.
Right.
And I'm wondering if, you know, somehow, you know, you're looking at a pretty wide continuum of behaviors in terms of risk.
Right.
There's no way to answer if that's in that 25%.
Well, there is actually. I mean, seriously, the SPANDAT actually captures that. It tells you, from the clinician's point of view, the lethality of the attempt. So that's one of the variables that it actually captures. So
well, it's his perception of the lethality.
It is,
but
yeah.
we wouldn't know if it's scratching with a toothpick or...
Right.
But in terms of like the clinicians who are rating these folks in terms of low, moderate, or high risk,
it's just a checklist, and that's the problem with just using checklists. The Columbia has a definition of attempts as well as the other, you know, the other variables. So, but when it was adapted, those definitions got dropped off. But now they're, incidentally, now they're reincorporated back in. I made them put them back in for this very reason. So, not to tip my hand here, but that is a limitation of your study. It's the checklist is only as good as the checklist is good, and so you're very right that the prior suicide attempts can encompass a broad range of behaviors, which we don't really know.
Is that listed as a limitation?
Yeah, it is. It is. And not only that, I mean, the whole process is very limited by the fact that so much of this is self-report.
But let me raise this point.
Yeah.
So given the potential consequence for the patient, the family, society, the clinician, the organization in which the clinician works, wouldn't you think that you would want to err on the side of overestimating the potential risk than underestimating it?
Yeah. Yeah.
So certainly, I mean, while there are obviously limitations to anything that we do, it really boils down to, and this is what your study's about, the perception of the clinician seeing the patient and how comfortable they are.
Yeah, exactly. Exactly right. May we move on? Okay. The third hypothesis, we actually looked at the individual categories, low, moderate, and high risk, instead of combining low and moderate as we did in the previous two, just to see if they independently can be associated. And again, using chi-square analyses, did in fact do a Bonferroni correction on these, and they still came at 0.05, and it still came out at 0.01 on all of these. So, because of the number of tests that are involved in this kind of well, there are a lot of tests, obviously. So in any case, ED providers differentially were able to distinguish between ratings of high and low risk on 14 of the total 15 risk factors, which I think is really, really good. That really is no surprise to me. I mean, I think it would seem that that would make a lot of sense. It'd be easier to get a sense of what is high and what is low. Moderate ED providers differentially distinguish between a rating of moderate and low risk, and this was the case for all 15 predictor variables. So they're actually, moderate risk was able to be distinguished from low risk, which I think is pretty cool. It had meaning. ED providers differentially distinguish between a rating of high and moderate risk on 11 out of total 15 risk factors. So it suggests that it was a little bit more difficult for them to distinguish or discern what is moderate and what is high. And here's how the data came out. Again, you can see even the chi-square values for high versus moderate were much lower, but still significant on a good majority of these. Okay. Last two hypotheses dealt with the outcomes of the self-directed violence, again using chi-square. The results for the fourth hypothesis suggest that a provider rating of high risk was in fact significantly more likely to be associated to veteran subsequent suicide event or self-directed violent event when compared with non-high risk. Again, the categories low and moderate were combined at non-high risk versus high risk. ED evaluators' ratings of high risk account for those veterans who subsequently went on to engage in self-directed violence at a rate of 5.5 times greater when compared to those veterans who were rated to be not at high risk. So that's a great finding. It's awesome. It works.
It works.
It works. And here's the data to support that, as you can see. And it's significant at the 0.001 level. Okay.
Elevation. You'd think the VA would like to see this published, right?
I would hope so, yeah.
I would think so.
Again, we wanted to see, does moderate risk work? So in this case, again, another chi-square analysis, rating of moderate risk was statistically associated with subsequent acts of self-directed violence at twice the rate when compared to those who rated at low risk. So again, moderate risk works better than low risk. While a rating of high risk was over 4 times more likely to be associated with subsequent acts of self-directed violence when compared to those veterans who were rated at moderate risk. And again, here's the data.
And that was really the original question, right? Does
Right.
moderate risk predict anything?
Does it mean anything? So again, Greg actually called this long before we even started collecting data. I remember this, Greg. You even said, you know, high's going to work better than moderate, moderate's going to work better than low.
Right.
Sure enough, it came out that way. So, so there it is. All right, so I'm going to kind of get into the discussion. Some of the limitations that you folks have already proposed, I've already put into this PowerPoint. So the good thing about this study is that, in fact, suicide risk categories do appear to work. They appear to be meaningful to the providers that use them. They seem to have clinical utility, and that has a lot of good practical implications for suicide prevention programs. You know, the risk factors are distinguishable. It appears to me that, you know, again, I can't account, that's part of the limitation because I don't know the expertise or the years of education or experience doing suicide risk assessment of these 104 providers. But nonetheless, I'm sure that factors into some of the results here. But again, think about it. This is a very naturalistic study. This is how things work in the real world. This is not a lab situation. It's very retrospective. And to me, it's very comforting to know that I mean, you know, people get so upset about when someone says, oh, I'm suicidal, and, you know, we fall apart. But it shows that, you know, maybe this stuff really does work. You know, and I would think it would increase some confidence in providers. That's one of the things I was hoping maybe this study would do. It would increase some confidence in people to let them know, you know what, if you know this stuff, you might be all right. Is 110 attempts out of a population of 1,560 reasonable? I'm not saying it's acceptable, but I'm just saying, is it reasonable? I don't know. You know, it's just a rhetorical question. You don't want to lose anyone. We had 3 deaths out of that entire cohort.
Yeah, that 3 deaths.
We had 3 deaths out of that entire
concern.
cohort. So, you know, I'm not saying it's acceptable, but in the absence of being able to predict and, you know, suicide still remaining elusive as a predictor, you know, I don't know. Provider ratings of high risk do in fact appear to capture a greater percentage of those veterans who eventually go on to engage in acts of self-directed violence compared to both low and moderate risk. And then again, provider ratings of moderate risk appear to capture a larger percentage of those veterans who eventually go on to engage in SDV compared to low risk. Statistical associations appear to be strongest when providers are distinguishing between high and low risk. We already brought this up, that high and moderate may be a little bit more difficult. With the omission of normative approaches, this project suggests that natural decision-making does a reasonably good job. And then again, you know, there is some criticism about the use of checklists. We talked about that as a limitation. I'll get into limitations of the study in just a minute. You know, I had, again, some concerns of the fact that violence was not significant, that violence towards others is not significant when the research suggests that, in fact, it is. And if you think about it, if you have trait impulsivity, trait violence, alcoholism, what does that do to your, ability to relate in the world and have relationships and associations? You know, if anything, that might drive hopelessness if you think about it. You know, where do you belong in the world? Well, I don't belong to anyone because I'm such a mean-spirited, aggressive, impulsive person that, you know, and I just can't imagine, you know, why. I think it could be a strong distal factor, particularly if somebody has trait aggression as part of their personality. So that's an interesting finding to me, and that would be a good thing if we were to do qualitative studies to get psychiatrists' opinions about that as to why that might not be something they would be looking for.
What's the base rate of that behavior in this population, or that risk?
A base rate of which?
Like, yeah, like how often? I'm wondering why it didn't differentiate.
Yeah, I don't know.
I mean, I guess what I'm thinking, does it make sense if it's occurring across the spectrum in these groups? It wouldn't be a differentiating factor. Right?
Yeah.
I don't know.
Well, here's the other problem too. At the VA, it's really difficult to get collateral from family. It really is. And you know, who better than the family to tell you, hey, what's this guy like when he's not there? I mean, people can, again, this is the problem with self-report. You know, we're kind of at the mercy of you know, what people tell us. And it really is difficult to get collateral information from the family. So we know that the person has a violent history, you know, they're going to commit domestic violence.
Think that.
Yeah. So that might be something that the VA needs to do a better job on, is getting collateral.
Is that because families don't present with the patients, or that they
Most
just
times
don't collect the data?
no. Most times they don't.
Because this was a checklist, it's a box that people check or not check.
Right.
You don't know if it's not checked whether the assessment was actually made or not.
Right.
Because it's, right, so it doesn't differentiate between not asked or missing.
Right.
And no. So, and that's the limitation of the checklist. It could be
Right.
that clinicians don't assess for aggression or violent behavior in
Yeah.
ED.
Would be surprised.
I mean,
Yeah.
it could be they don't ask about it.
Right.
So whereas they are more routinely would ask about violence towards self.
Right.
Right.
Yeah, they're looking more for imminent risk to see whether or not they have to hospitalize or
Right.
not, and they're not really looking at chronic
Right.
distal factors, which is why, you know, there's some research or some discussion about using two risk, like a bifurcated risk stratification process where you not only rate a person at acute risk, but you also rate them at chronic risk based on distal factors, which I think is a great idea. You know, think about it. I mean, you know, especially people with physical, sexual abuse histories, you know, all the things that we don't typically look for in a suicide risk assessment. But I would think, wouldn't that be good to know for people that are managing these folks in suicide prevention? You know, so that's not, I think that's not a bad idea down the road to do that. I'm sure you read up on a little bit of Again, it didn't seem to matter so much whether the risk factor was modifiable or not in terms of the provider's decision-making in this case. Limitations, again, some of these we already discussed. We didn't factor in the role of protective factors in this study. They do have a checklist that there's 14 protective factors, and they're evidence-based. Greg will tell you in a heartbeat that you never come to rely on them. Oftentimes, you never overestimate the protective factors. Again, the problem is we don't get collateral support. We don't get collateral information into the VA. So we have to take the veteran's word a lot of times, and it really, that becomes problematic, I think, a lot for people. You just really are operating in a vacuum there, and it's just, you don't get a lot of information. That's the problem, and it's a high-risk situation. So I really give these guys a lot of credit that work in the ED that do this every day. It's just, it's remarkable. Again, idiosyncratic approach to suicide risk assessment. Again, we don't know what the training experience is. I already discussed that. There is no inter-rate. Greg brought this up. There is no inter-rate or reliability for use of that checklist.
I would add in my previous comment that
yeah.
it doesn't distinguish between not assessed and no.
Not assessed and no, right.
Is
You
that
know, I've
something
heard
that
also
there's a
sometimes
modifier?
semantics, not assessed and no.
No, these are not, they're not operationalized, right, Greg?
That's correct. And they're not operationalized, it's another
Yeah.
problem.
Okay.
But as far as from a psychometric point of view, the reliability is the big, I mean, that's the main one.
That's the main one, right. Clearly, the study is limited to an urban setting. I would suspect that this was done at the Wilkes-Barre VA. You'd have maybe a different outcome because they have tremendously high record of completed suicides or death by suicide. They're much more than the Philadelphia VA has. So older white males with firearms, unfortunately, in rural settings. So you know that would be certainly. I'd really love to see how this would come out in a place like the Wilkes-Barre VA.
And differences in socioeconomics too.
Yeah.
All the opportunity that was there is gone.
Gone. Yeah. That's a tough place right now, I know, it has been. Again, the low base rate for suicide makes most research very difficult to do. Future research, I think it might benefit the VA to replicate this in a few different sites to see if it's replicatable, see if it have similar findings. Certainly qualitative data, research design from emergency department providers might be helpful. Talked about the possibility of trying to see if any of these risk factors do in fact come on to predict self-directed violence using that, or survival, logistic regression or survival analysis. And I think that's it. I have just the references left. So I think I did that in 30 minutes or 35 minutes. I'm amazed. So I'm open to any thoughts or comments that you all might have.
I did have one comment about the suicide behavior reports and the SPAN data, and what you mentioned that the reliability may not be so great for the checklist. But what about the reliability for the suicide behavior reports?
Yeah.
Same with the
Same problem. It's all very subjective.
Exactly.
It's very subjective.
And then I did have an overall question to ask, and that is, what's the most important thing that you've learned from this project?
You know what? Because I supervise with Dr. D. Tomaso. I come in here sometimes. I say, God, I think about this stuff all the time now. You know, it's just amazing. I think about. I don't know. It's really amazing. And I'll say this is personal. This is a visceral effect. When I was collecting all this data, I mean, I spent weekends and weekends and weekends at the VA. I mean, I spent a lot of time. My wife can attest to that. Getting this data out of there, and it's like after a while I started seeing faces of these veterans. I really did. I mean, I was starting to get really personally, I was starting to feel like depression, you know, just going through every one, because I was like seeing every one of these people that I was going through, and I don't know, I think it just makes me a lot more compassionate. I'm on the fence about whether I have any moral prescriptions against suicide. That's kind of changed a little bit, and I think part of that is based on the fact that I did hospice work for 3 years, and I don't know, I just haven't. I'm a big believer in self-determination, but on the other hand, I struggle with the fact that if somebody has the ability to have a long, healthy life, and they're just making a crazy decision, you know, based on cognitive distortions, then that bothers me. And I like Joyner's theory. I know you get me away from that. I kind of like Joyner's theory, like interpersonal theory a lot. I mean, the whole idea of lack of belongingness.
Right. But if you had to pick one thing, what you got out of this project, that would be?
Well, to be a better researcher, that's for sure. If I can say that, that's certain. I've learned a lot about research.
And what was the one thing you learned about research?
Being mindful of how you construct it, not overthinking it sometimes. I think I got that from you, because I think I was trying to overthink it too much.
Okay.
And you really helped me to kind of rein it in a little bit, so I appreciate that a lot.
Okay, great. Thank you.
Thank you. But Dr. Golden, hi.
Gerd, hi. I apologize, Gerd.
Oh, it's okay, understood.
Little water main break here.
Okay.
But again, I realized that obviously this was the veteran population, and you know in the center that we have concerns as well about our evaluation process and things like this. And there's no perfect process. As far as a checklist and things like that, I guess it's kind of be careful what you wish for. You came out with such excellent results. I'm wondering if you would consider looking at some of our paperwork, and you know, in the next couple months, and maybe we could work together on that. The other piece that I'm
You'll have a lot of free time then.
I'll have lots of free
He has
time.
nothing
Yeah.
to do.
I have nothing to do.
Especially
I have a few
weekends.
more months with him.
Such a slacker, you know.
So I'm going to take full advantage. But the other piece that you commented on was the qualitative behavior of the clinicians and things like that. And you know, we've had some issues, some critical issues, unfortunately. But could you comment a little bit more on the qualitative piece that you remarked about, your sense of that?
Sure.
What might be good clinical qualitative response on the part of clinicians? And I realize that's a wide open question.
I have to say, I haven't done much. I haven't taken any courses actually in qualitative research methods. But the one thing I think about sometimes is, you know, again, visceral effects that people have when somebody says they're suicidal. I really think there's an art to it. There's a guy named Shea, I think Sean Shea is that first name. He's a psychiatrist, does a lot of work on just learning how to elicit suicidal ideation from people, asking the right questions. You don't want to ask, I find that even true at the VA a lot of times, you know, I would ask questions like, you know, if you were dead right now, who would miss you? And it really tells you a lot, because it tells you what their world is. And what, you know, is their world really unviable? Do they really see their world unviable? There's actually a newer suicide theory called worlds theory, where they're looking at that. You know, and you're trying to get a sense of how unviable is this person's world. I think Dr. Rosenfield actually turned me on to that article. That's really good. But you know, trying to ask the right questions, eliciting that information. People, for example, handguns, easy method for death, right? So people are very defensive about their guns. So how do you put them at ease? You know, it's again like we could use good cognitive behavioral therapy. So we say, well, you live in an area that's so dangerous that you really need a handgun for protection, right? I never had any problem with that. People saying, yeah, you know, if you live where I would, you would have one under your pillow too, you know? And so, you know, the whole idea is to elicit. I really think that's key. If we're going to use clinical judgment, we're going to do interviews, we really need to learn how to ask the right questions. What do most people do? You suicidal? Yeah.
I agree.
No.
It is an art.
Yeah. I mean, studies suggest that, you know, Scandinavian studies say 35% of the people that go on to complete don't even tell their families. So why would they tell you as a mental health professional? You know, I think maybe even higher than that. You know, not everybody needs a note. You know, and So I really think that's the piece of it. You know, I think people are quick. A lot of people also underestimate. I think they say, especially working with personality disorder people, they really are at high risk. You know, you think about what a torturous way to live your life. But what do? We say, well, they're just gesturing. They're just trying to get attention. So that's where I think the qualitative stuff would be really useful.
And the education to reduce the anxiety and putting people at ease is critical too.
Yeah.
Well, it's interesting to me because, you know, when you think about the process, you know, these are people who only were assessed in the emergency.
They could have been assessed by their outpatient providers. They also are required, if they are hospitalized, they're required to get the same assessment before they leave the hospital, which is why I think that they ought to use a bifurcated risk stratification
Some
system.
kind of acute distress? Yes? No?
If
There being some kind of acute distress
yeah,
at
yeah,
the time.
yeah.
I mean, not everybody who enters the system up front gets this kind of evaluation, correct?
Not everybody, but it's VA's policy that if a person says they are suicidal, the provider, whether it's outpatient or
They have
not, has to
say
do
that,
one of these
but
risk
They have to
assessments.
say that.
Correct.
So as a matter of screening everybody, whether they report I'm suicidal or not.
Yeah, right.
But, you know, I guess what was interesting, another qualitative thing is this, you know, the idea of kind of like flight into health. Is it once you say I'm suicidal in the moment, and then, you know, you've drawn attention to yourself, and now, you know, the clinician in you, you know, just kind of like, oh my goodness, now I've drawn attention to myself. Now there's consequences to that.
Right.
And some people will back off from that, you know, just say, you know, I was just momentary, I don't know what I was thinking, I'm good. When in fact they may still be at risk,
Right.
but they are, it's a kind of flight into health, right? They're
Right.
backing away from it.
Right.
And really only a good clinician's interview who could really talk them through that, you know, would get to assess a little bit more. It was just more of a comment, but
Right.
I was speaking to the clinician in you.
Right. I hear you.
You know.
So Gert, let me ask you
Sure.
this. So you have a large database here,
Mhm.
right? And so a couple of things. One is there's a lot of variables, and I think Greg brought up the issue of the reliability of the individual items. Could you think of a way that you might be able to statistically package some of these items together to make them more reliable subscales?
With your help, maybe.
Well, I guess what I'm thinking is, you know, almost like factor analysis.
Factor analysis, so
Factors.
maybe
And
making
I
a
wonder
computer out of it.
whether there might be some way, maybe, you know, maybe all of these items on the checklist boil down to 2 or 3 dimensions that might constitute a more reliable dimension in the prediction. I mean, it's just something, obviously you're not going to do that now, but just something to think about. The other question I had is that with the size of the sample that you have, obviously you're going to pick up even small differences, right? Because I'm sure you have a lot of power in this. In addition, you've also done a number of statistical analyses on the same set of data, which creates the problem of finding results that may be due to chance, right?
Right.
But we talked about this the other day. We looked at the Bonferroni corrections, and I don't think you lost any
Didn't lose any.
of the distinguishing variables, so that's good. That being said, when I looked at your Kramer's V, which is really the phi coefficient, right? Those values, they're correlation coefficients in a chi-square. They range from 0 to 1, as you know. Closer to 1, the more stronger the relationship. What were your Kramer V's in this study?
Most of them were not so hot.
Yeah, I mean, they're around, you know, I mean, one of them I recall, if we round it, we might get it to 0.30, which would mean if you squared that and did a coefficient of determination, about 9% of the variability in the outcome is attributable to differences on the predictor variable. So my question to you is, what happens to the other, what do you think accounts for the other 91%? That's not included in this analysis.
Mhm.
I don't think there's an easy answer to it,
No.
but, you know, what do you think? You, for example, mentioned you don't get much collateral information.
Collateral
That's sort of the
information.
nature of the beast, it's just the way it is.
Yeah.
But if you had to think of some other variables that may make the difference between high, medium, or low risk, what do you think they might be?
Well, maybe some of those are interpersonal too, you know, when I'm thinking, again, cognitive variables of the clinicians actually doing the risk assessment. If you think about their cognitive styles. Those could be.
Let me ask you this. So for example, in the patient's life, is there anything on the checklist that addresses the support system?
Yes.
There is?
Yes,
Okay.
yeah, protective factors are
Protective.
involved. And that's what I'm saying. I mean, we don't know, and that was in my limitations, I don't know how
Yeah.
much the protective factors accounted and how credible those protective factors
Right.
are. It's, again, the perception of the
Sure.
ED physician to, you know, a person says, well, you know, I would never kill myself because I would go to hell. You know, we don't know how true that really is, but, you know, we did have actually an African-American ordained Baptist minister did just that. He shot himself in the
Yeah.
shower, you know, so can't always go to rely on protective factors sometimes. And that's the problem. I really think it's just, you know, I hate to say this. I hate the word manipulation. I really do, but a lot of times I think that's what we don't know what the person's agenda is a lot of times, and it's uncertain. We try to give people the benefit of the doubt, you know what I'm saying? And you try to do the right thing, but is it credible, the information you're getting from the person? I think it really becomes difficult for people sometimes. Is it, you know, because you have resources you have to worry about, not overusing resources. You don't want to take somebody's civil liberties away by hospitalizing them and end up with some iatrogenic effects from that. So, you know, that becomes so difficult for, I think that's really where it is, Dr. DeTomaso. So I think it's just the idea that we don't have good data sometimes.
Yeah. You make do with what you have.
Yeah.
So, which is why I like this study, because this is exactly the conundrums that most of these providers are in, and they still were able to pull out, in my opinion, we're still able to do a pretty good job in spite of all of that. I mean, my hats are off to these guys and these individuals that work in the ED.
Yeah, I mean, if you're concerned about the word manipulation, function is probably a more useful term.
Yeah.
You know, what function?
What function does it serve them to
Right.
do
I
that?
mean, the other interesting thing is, you know, I suspect that people who end up in the ER probably have had, I think Bruce alluded to this earlier, probably have had a couple of assessments
Mhm.
before they even got there.
Mhm.
And so, you know, that may change what they say. And certainly we've run into that in the clinic, you know.
I mean, I think this could be a specialty in itself. Somebody
Yeah.
could just do this for the rest of their life and do this and become an expert at this and probably do
We
very well
all
with
need
it. I
to
mean,
know
just,
it. We all need to know it.
yeah, yeah.
Kurt, I have one other, this is just a little technical thing, and it may be, the manuscript that I had was from October, so perhaps you've
Yeah.
updated since then?
Yeah, I sent you some updates on that.
But
since
there were,
then.
that's when I printed out, some of the references that are in your slides, I didn't find in here.
Right.
So maybe it's just because I have but if you would just check, like each of your references
Sure.
to make sure that they're in
Yeah,
here.
they're in the,
In the most recent
Yeah.
version, okay.
But I will say, Gerd, you put an enormous amount of effort into this. I think you did a great job.
thank you. Thank you.
Publicly
Thank you,
thank
Dr.
Greg
Brown, because he's
for his involvement. You know, I think it's interesting and neat study and.
That was a great idea.
So should the VA use moderate risk throughout the VA system?
I
If
think
you
so.
were a policymaker?
Well, if I
Would you
understand
recommend-
correctly, your Safe Vet program was designed around people who are at moderate
Right,
risk,
that's
right?
exactly right.
So it makes sense that that program continues,
Right.
and, you know, we really maybe want to focus on that, but I think the added step of putting maybe a chronic suicide risk factor in there, in addition to an acute, would be a good one to do too. Because they're not looking at them, they're not looking at historical factors, so. But, yeah, so I don't, this hopefully will, it means it's something that would give you, will keep the Safe Vet program going.
I don't know about safe vet, but I know
Yeah.
that, well, we're working on those results now, but
Right.
Certainly there's not a lot of studies done like this in VA, so
Mhm.
I'm sure this will get some press. So, yeah, good job.
Thank you, sir. Appreciate it. Thank all of you for your support through this and the project and all the advice that I've gotten over the last few years on this. I appreciate it. All comes down to this, doesn't it?
So for a couple of things, could you say that there is the greatest predictor of getting a severe or moderate rating?
High rating,
Mhm.
the predictor that would most likely get you a higher. Again, I think based on this research would be the past history
Mhm.
of a report of an attempt.
Okay, and if we had to differentiate what's getting people a high versus a moderate, could you identify the variables?
Mhm.
In other words, what variables did you identify?
Again, I don't know what role protective factors came into play there. That could very well be the deciding factor. But yeah, I hear your question. I understand
Yeah.
the question. I'm not sure.
It'd
It's
be interesting to
that easy.
clearly kind of
Right.
elucidate that.
I don't know if we go back to the slides again. That might be helpful.
Be nice if you could lay that out in the discussion.
Yeah.
Right, Greg? It sounds like people would probably be pretty interested.
I mean, I have odds ratios.
Mhm.
Now go back.
Is this one here or this one?
Yeah,
Yeah. Here we go.
high versus moderate.
Well, these are actually high versus high versus moderate. So yeah. I can't tell from this.
Yeah, that's okay. You can go back. That might be one thing we
Right.
can add. The other thing was, and I know we're not including it in this final edition, but the research you did on the 3 completers was interesting. Greg, do you think that would be worthy of a second study, or maybe kind of a pilot to a bigger study?
I'm not sure that in and of itself it's going to be publishable, but
Because
certainly
it's
the VA would be interested in that.
Okay.
But I'm not sure that in and of itself, just doing.
You're not suggesting a second dissertation?
I want to add a
And a
caveat.
second degree, yeah.
Two of those suicides happened under the Philadelphia watch, and then one of them actually occurred in another VA, but that person was part of the cohort. They just chose to give their services at another VA.
I see.
Right.
And
I mean, suicides are a white hot topic for the VA.
right,
So any insight that you might have on the 2 that you know about, or
Yeah.
the 3, I'm sure people will be very interested in that.
I do know the only risk factor that came up common for all 3. I hate to say this. 2 of them were at the ED were rated as low.
Okay.
Okay, and
Yeah.
so again, this is a good reason why you have a bifurcated risk stratification system. Let's look at chronic, and I did a little study on a little bit of that to try to get what I can. You're limited, but the only risk factor that came out common to all 3 of those was agitation, severe agitation. I thought that was interesting.
Interesting.
Yeah.
So this is why I'm so interested in this. It's nice that the docs are differentiating between low, medium, and high, and it's nice that they're reliable, but in the scheme of things, if they're not predicting actual suicide, it's kind of academic. And I'm wondering, that's why I wanted to look at those completers. Really, what are their ratings telling us?
It's such a low
What's
base rate.
the validity?
The base rate is so low.
I know.
Yeah.
I know.
You
That's
probably-
why you have to expand
Which is
beyond
why,
this.
which is why you get away from prediction and get into prevention. That's
Yeah.
all we want to do. We just want to identify people who really we believe are at the highest level
But
of
to
risk so we can
expand this-
manage them.
you think about it across the country, if, I mean, if 22 guys are committing a day, and that was the reason I was asking within the system how many are completing.
Right.
Now you have some data, now you
Yeah,
can,
that's interesting.
right?
Because you don't have, I'm sure many of these people, folks never show up
Mhm.
at the VA, much less the emergency room.
Right.
So, you know,
Yeah.
but how do you capture them, how do you?
Well, that's part of the problem, yeah.
Mhm.
Yeah.
Is there any kind of psychological postmortem that they do, or that's what you call it?
They do there, yes, yeah. They do a postmortem afterwards. I mean, usually it's chaired by the psychiatrist who happened to have had the case, and people, public is welcome to attend it.
That's what
They go over
Gonzalez
case
was
records and
doing
things.
in
Yeah,
the prison. One of our grads, Travis,
yeah.
was doing psychological
Postmortems, yeah.
There was like a niche for him, so it was absolutely fascinating.
Yeah.
Because they probably had a lot more data.
So the hope is that between this, each VA site has a suicide prevention team, usually social workers or psychologists who are involved in tracking all this, doing interventions with people who are deemed to be at high risk. So it has practical value here as well. We don't know, I can't tell from this data whether or not that means the program's working or not.
Right.
I guess you could probably run some statistics there. But Greg had also designed the Save Vet program, which was initially identified to capture veterans who are at moderate risk too.
Mhm.
So I think if you capture moderate and high-risk people, which still overall constitute a small number of veterans overall, maybe doing something very good here,
Important
something
group,
practically, yeah.
So one more question for you. On the slide that you had with the combat rated versus non-combat rated?
Yes, I think that was like the demographic characteristics of the study. There we go. Let me hit escape on that for some
Yeah.
reason. There we go.
Greg, you might know this, I'll throw it out to you, Gert, first, but in the overall statistics, combat rating, I'm assuming confers greater risk?
Doesn't suggest, the studies don't suggest that at all.
Yeah, it's counterintuitive,
It is
isn't it?
counterintuitive. I think it's poor coping, to be honest with you, just from my own work with veterans over there. A lot of these,
Combat
especially,
is not increasing or decreasing coping.
I think a lot of these folks had
If you look at it.
problems with emotional regulation, impulsivity before they even went into service,
Mhm.
and they don't screen real well for that.
What proportion?
Pardon?
I'm sorry. I was gonna say, what proportion have PTSD?
That I don't know offhand. I can't remember the exact number. It's in my manuscript, but it's not to say PTSD confers. I mean, there's a lot of studies on this.
Mhm.
I'm thinking of Kang and Goldman. They did a lot of studies on Vietnam-era vets and found that it's not necessarily a major risk factor. A lot of these guys, especially if you think about it, I mean, the mean age is 54 years old, so that accounts for post-Vietnam era veterans who likely did not see combat, okay, like myself, okay? And a lot of these guys enlist. I have to say the majority of these guys are enlistees. They go in at 18 years old, and I can say for a lot of these folks that at least I've worked with individually, they come from pretty tough family origin issues where there's a lot of abuse, alcoholism, mental illness.
Adverse child experiences.
Yeah, and I think they're already, if you look at it from a diathesis stress kind of thing, maybe the combat just exacerbates it. But I think a lot of them already had difficulties before, psychological difficulties before they even went in. I mean, you go in at 18. So they need to do probably a better job doing psychological screening at recruitment stations, in my opinion.
Yeah.
They don't. I can tell you the truth. I had a guy, I went to Parris Island, South Carolina for boot camp, basic training in the Marine Corps, and the first day we were sent over to the squad bay. The fellow across from me, as the DIs are screaming their heads off at everyone, he just froze into a catatonic state. We never saw him again. He just froze. He was completely catatonic. I've never seen anything like
Well,
that
I mean, the
before at that age.
contingency for recruiting
Yeah.
precludes assessing these things.
Yeah. Yeah. So, those are just my thoughts.
In thinking, I think we can benefit from this because we can consider how we're assessing suicide. Greg, do you think we're currently using the BSS as one of the instruments? Do you think the Columbia would be a better instrument?
It's sort of like apples and oranges. It's for what? For the needs, you have to.
Clinical suicide assessment?
Oh, I think using both would be
In
good.
community-based clinics, for example.
Community-based clinics, the problem with the SSI, while there's a lot of data around it, it's lengthy. If you
Or
score
the
positive.
BSS?
The BSS is lengthy, it's 19 items, and
Yeah.
so, although there's 5 screening, and, but it is you can use it as self-report, which helps out with it. But I think it really comes down to an issue of feasibility and the needs of the clinic rather than which instrument is better per se. But certainly the Columbia does a much better job with behavior than does the SSI doesn't really get at behavior at all. It gets at some preparatory behaviors, but doesn't do a good job of assessing 4 attempts. There's 1 item, but it's not as good as the Columbia.
Okay, great.
That
So consider
matters.
It's online too.
It is online. You can. It's free. You can download it.
Why not,
And
right?
there's training
We'll
videos.
certainly look at it, incorporate it.
Um,
The hooks and scales that we use and things like
The University of Pennsylvania Health System is now rolling this out across psychiatry, so we're using it there. In the ED, inpatient unit, in outpatient psychiatry.
BSS?
We're using it as the main one.
Okay, great. Okay, good.
Good.
All right, great. So, how about if we discuss your presentation now, and, yeah.
Okay.
All right, so thanks, everybody.
Thank you so much, everybody, for your kind attention. Good questions.
Right, nice judgment. Okay.
Thanks.
Got my head in psychology.